So we are finally seeing plateau in multiple myeloma. And that is why it is important that we define cure and we talk about that we are curing myeloma patient and move the field forward.
In this video, CancerNetwork spoke with a number of hematologic oncologists regarding key findings from presentations they gave at the 2025 Society of Hematologic Oncology annual meeting. First, CancerNetwork interviewed Sundar Jagannath, professor of medicine at the Icahn School of Medicine at Mount Sinai Health, about his presentation on defining a cure in the management of multiple myeloma.
It is important to change the dialogue in multiple myeloma. Is it time to talk about cure in multiple myeloma? Why is it so important? Let's put it in perspective. First of all, for the patient to be told that this is a curable cancer is completely different as opposed to being told that they are inflicted with an incurable, invariably fatal cancer. So it makes a big difference of giving hope to the patient. Secondly, for the treating physician, it's very important that they understand that at this time, myeloma is a curable cancer, which means they are engaging in patient care in a completely different way. They are keeping themselves up to date on what is the latest treatment. They are referring the patients for clinical trials with the potential for cure. So that makes a difference in how the physicians approach the patient. So new clinical trials could be developed in newly diagnosed myeloma with a cure as a goal. For the FDA, EMA, for regulatory, it is also important that there is an evidence-based endpoint whereby they could approve drugs earlier in first-line therapy. And also, clinical trials can happen. Newly developed drugs could actually come in clinical trial in second line and third line in a randomized fashion. So there is a lot of benefit to say that. So now that we have a definition for cure, why is it so important at this time? Because newly diagnosed myeloma patients are receiving quadruple therapy, both in transplant eligible patient with transplant and in transplant ineligible patient. And the results are showing that even at 2 years, many of the patients are able to achieve complete remission, MRD negative. And even if you do what we call as a 2-year landmark analysis, patients who are MRD negative at 2-year mark, 80% are all still progression free. And these studies are ongoing, and we will be able to do annual MRD testing, and we will be able to define how many years they have to be MRD negative to reach a plateau. So we are finally seeing plateau in multiple myeloma. And that is why it is important that we define cure and we talk about that we are curing myeloma patient and move the field forward.
Next, Adam Olszewski, Associate Professor of Medicine at the Warren Alper Medical School of Brown University, discussed his presentation of the Phase 3 SUNMO trial comparing mosunetuzumab plus polatuzumab versus R-GemOx in patients with relapsed refractory multiple myeloma.
There is still a high unmet need for patients who have a relapsed refractory diffuse large B-cell lymphoma and who are unable to access or undergo potentially curative treatments. Historically, this involves chemotherapy and autologous stem cell transplantation. Now, maybe more commonly in the United States, CAR T-cell therapy. But studies show that a substantial proportion of patients are unable to access this treatment or for different reasons ineligible to get them. We had previously shown in a phase 2 trial that the combination of mosunetuzumab with polatuzumab vedotin provided high response rates, which appeared to be durable. And that led to the global effort to provide this therapy as an experimental arm for a global phase 3 trial, comparing it to R-GemOx, which is a commonly prescribed chemotherapy regimen for these patients. And this trial was conducted in multiple countries across many continents. This treatment was delivered safely as an outpatient for 208 patients enrolled in this trial. And with positive results, we think that this will create an additional option for these patients beyond R-GemOx chemotherapy, which admittedly is suboptimal, as we had known for many years. Had, interestingly, a dual primary endpoint for both overall response rate and for progression-free survival. So both were accounted for statistically. And the trial was terminated early because early analysis of the overall response rate demonstrated statistically significant improvement. So ultimately, the trial enrollment was terminated by the Data Safety Monitoring Board, and both co-primary endpoints, so both overall response rate and the progression-free survival, are improved with mosun pola compared to R-GemOx. Most importantly, the progression-free survival was extended from 3.8 months for R-GemOx, which, as we know, is very suboptimal, to 11.5 months. It's tripled or more compared to the control arm. And the overall response rate was 70%, with 51% of patients attaining complete response, which is also significantly better than the 40% response rates observed with R-GemOx. So both from the point of view of response rates, complete response rates, and the progression-free survival, the experimental regimen with mosun pola provided benefit for patients.
Finally, Francesca Palandri, an adjunct professor in the Department of Medical and Surgical Sciences at the University of Bologna, highlighted insights from her session exploring predictive efficacy biomarkers for ruxolitinib for the treatment of myelofibrosis.
We actually have been using ruxolitinib for nearly 15 years now, and this drug has proven clear superiority of BAT, for example, hydroxyurea and corticosteroids, in the control of splenomegaly and symptoms. Still, the response rates vary a lot, and we have 40 to 70% of the patients that finally will fail ruxolitinib and will discontinue the drug by 3 to 5 years. And that's why it is so important to assess predictors of response in order to orient our clinical decision strategy. We recently observed that in a real-life context, over 40% of the patients started ruxolitinib with a dose which is underdosed compared to their baseline platelet counts. And this decision to start with lower doses is possibly related to the concerns over an early hematological toxicity. However, for the patient to start ruxolitinib underdose, the probability of spleen and symptom responses is much lower. The rate of discontinuation of the drug is higher, and overall, the overall survival is decreased. So that's why it is very important to, as an educational point, to recommend to use the higher tolerated dose. We also got some other insights that are doctors related, which concerns the timing delay from the diagnosis of myelofibrosis and the start of ruxolitinib. For example, both in a real-world study from Italy and in the prospective subcohort analysis of a COMFORT study, we actually observed that if we delay the start of a treatment more than 1 year, then the probability of response and the overall survival of the patient is decreased. So that's why a timely initiation of treatment could be a real prognostic marker in our hands.